first introduce both the speakers, and then we will have pre-recorded talks by Dr. Dheeraj Gautam and by Dr. Nalini Bansal, and then we will have a question answer session. You are welcome to put your questions in the chat box or in the Q&A. This session is also transmitted on the YouTube channel of Indian Society of Organ Transplant, and therefore any questions that come up there will also be discussed in this forum. So first, Dr. Dheeraj Gautam, he is the head of pathology, director of pathology at Medanta in Gurgaon. He is a very accomplished pathologist with over 2 decades of experience and has seen more than 2 lakh biopsies, has more than 50 publications, and is participant in more than 20 national and international studies. I've personally worked with him, and we share a very close equation. He's also done his fellowship in transplant pathology from Pittsburgh. Welcome, Dr. Dheeraj. Then we have Dr. Nalini Bansal, who is the principal director of Institute of Gastro and Hepatopathology. She has a large experience in histopathology and has special interest in liver pathology. She has more than 85 publications to her credit, and she is also an associate editorial board member of Indian Journal of Pathology and Microbiology. And she is a member of various societies and has written a book on liver biopsy too, which is one of the first ones in this field. So welcome, Dr. Bansal. Now we'll start with Dr. Dheeraj's talk. So let's start with Dr. Dheeraj Gautam's talk, please.
सर स्टार्ट कीजिए सर.
Okay, so good evening, friend colleagues. So today's topic is perfusion reperfusion injury in a liver transplant case, a pathologist perspective. So a very brief history about the liver transplant pathology. First orthopedic liver transplant was first performed by 1963 by Thomas Stalls at UPMC Pittsburgh. And Stalls and his colleagues performed 8 successful transplant children in 1967. And I'm fortunate enough to be trained at the same place in UPMC. So, and what are the stats? Why this liver transplant is so important is nearly 70,000 patients in the United States are currently on the liver transplant waiting list, but only 7,500 liver transplant are performed annually. So up to 18% of the there's a reverse scenario between US and India. In US, around 80% of organs are from deceased donor, and in India is around initially it was 85%, but around now 7 to 75% are LDLTs. So the 4 main indication of liver transplant are chronic liver disease, acute liver failure, malignancies, and metabolic disorders. So I will give you a chart here. The pathology of the liver transplant depends mainly upon the time period. Like if you are doing the biopsy on 0 day, then the common complications are donor disease, that is steatosis, preservation injury, hyperacute rejection, and primary non-function. And less likely, there's no less likely complication on the day 0. But if you come to day 1 to 7, Then preservation injury, hepatic artery thrombosis, portal vein thrombosis, bile duct leak, and acute cellular rejection in this uh, order, they are important. And less likely are hyperacute recurrent viral hepatitis or sepsis and small foresight. But if you come to 1 week to 2 months, then acute cellular rejection will come on the top of the list. Recurrent viral hepatitis, preservation reperfusion injury, biliary complication, and drug reactions. So, and 2 months and beyond, it can be acute rejection, chronic rejection, recurrent liver disease, acquired liver disease, biliary complication, and less likely are persistent preservation reperfusion injury or PTLD. So, today's topic is preservation injury. So it can come into day 0, day 1 to 7, and 1 week to 2 months. So in all three timelines, it can be present. So what is the clinical picture of preservation and reperfusion injury is elevation of serum transaminases, poor bile production within first 24 to 48 hours. Clinical resolution is usually achieved within 1 to 4 weeks. But abnormal liver tests, they can persist up to several months if the injury evolves. Then it leads to higher incidence of subsequent acute and chronic rejection, increased severity of recurrent HCV, and higher incidence of biliary complications. The differential diagnoses are part of, it can be part of rejection, then ischemic biliary injury, sepsis can be one differential diagnosis, ascending cholangitis, which usually follows the perfusion reperfusion injury, and large bile duct obstruction. So, perfusion injury, it occurs like pre-preservation injury, then cold preservation injury, then rewarming injury, and then reperfusion injury. So, it is generally categorized into two types. One is cold ischemia and second is warm ischemia. Cold ischemia preferentially targets the sinusoidal endothelial cell, and warm ischemia primarily damage the hepatocytes. So, both the component endothelial as well as hepatocytes are affected. Image study show no evidence of biliary ductal obstruction. So histologically, what you will find is cholestasis, microvesicular stenosis, not the macrovesicular stenosis, then hepatocellular necrosis, especially in centrivenular zone. Then the histological hallmark is zone 3 hepatocyte ballooning. However, there is no evidence of rejection. So, the energy deficient vascular leakage, inflammation, no reflow phenomena, transcription reprogramming, and cell death. These all leads to the ischemia reperfusion injury, which ultimately lead to primary graft dysfunction. So this is primary graft dysfunction. These all entities come under the umbrella of primary graft dysfunction. So what is the concept of perfusion reperfusion injury? After prolonged ischemia, re-establishment of blood flow, that is reperfusion, does not relieve the ischemic injury. So this is a paradox component. On the contrary, it aggravates the tissue injury. So ischemia leads to injury, and when reperfusion occurs, then it will lead to the more injury. So this is a paradox. So in this paradox, there are multiple components of the paradox. So factor influencing IR injury are duration of ischemia, then collateral circulation, which is very, very poor in this in liver transplant, dependency on the oxygen supply, and condition of reperfusion. So paradox of, as I already said, paradox offers several types. So first we will talk about the oxygen paradox. So low oxygen leads to perfusion injury, and When oxygen containing fluid is circulated, then there again perfusion, which leads to the more injury. So what is the pathogenesis? I will come later on this. So there's a second part is calcium paradox. If there's a calcium free fluid, then it leads to perfusion injury. Then you give the calcium containing fluid, it again do the reperfusion injury. So then the third is pH paradox. So if there's an acidosis, it leads to tissue injury. After ischemia, there's acidosis which leads to tissue injury. Then there's a collection of acidosis in the reperfusion, which again leads to the tissue injury. So the reactive oxygen species, that is ROS, it's a group of chemically reactive molecules containing the oxygen. The classification of ORS are two types. One is oxygen free radical, that is O2, OH and LO. Non-free radical, that is O2 and H2O2. So there's a clear-cut relationship between the free radical and reactive oxygen species. So the few component, that is oxygen free radical O2, OH, these are reactive oxygen species as well as the free radical. So it will ultimately leads to the DNA damage, which ultimately leads to the cell membrane destruction. So what is the mechanism of calcium overload? It operates through the sodium calcium exchange dysfunction, which uh, leads to the damage of the cell membrane and damage of the mitochondria or SR membrane. Calcium overload during the IR, the concentration of cytosolic calcium increase, obviously causing cell damage and dysfunction. This phenomena is called the calcium overload. Now there's another pathway which is xanthine oxidase pathway, that ischemia leads to decrease ATP and increase calcium, and decrease ATP leads to hypoxanthine, which after reperfusion with the oxygen converted into the uric acid. So the free radicals are highly reactive group of atoms, molecule of the radicals, which carry unpaired electron in the outer orbit. Properties of free radicals are they are chemically active, they are highly oxidative, and they have a short half-life. Oxygen free radicals are free radicals that contain the oxygen. So it leads to the summary of the pathogenesis of IR injury. So what is the summary? Ischemia occur, which leads to the cell necrosis. Then reperfusion occur, which converts into the tissue recovery. But the reperfusion and ischemia, it operates into the three pattern: calcium channel, neutrophil, and oxygen channel. Calcium leads to the calcium overload, neutrophil, increased inflammatory factors, and no reflow. And in oxygen, there are free radicals, which leads to the cell damage. So if there is a marginal donor allograft, then there is a macrosteatosis, there is a circulated death, advanced age, or large cold ischemia time. This all leads to mechanism of ARI, but the surgeons usually use the hope that is an oxygenation mechanism which reduce the ischemic perfusion injury. So the clinical outcome in acute cases are post-perfusion syndrome, graft injury and dysfunction, primary non-function, acute rejection, or impaired liver regeneration. Long-term sequelae are ongoing inflammation, chronic graft damage, fibrosis and graft loss, and biliary complication and recurrent liver diseases. So this is an article in which there's a 5-year experience of human DCD liver transplantation treated by hypothermic oxygenated perfusion, that is O, before the implantation. So they have done 50, the average age was 53, the cold time average was 17 minutes, 4.7 hours, and the temperature was 3. So they have compared with the cold storage, and other group was hope treatment after the cold storage. So if you can see in the cold storage, the ischemic cholangiopathy was 10%, hepatic artery thrombosis was 12%, primary non-function 4%, and sepsis chronic rejection 6%. But if you use hope, then ischemic cholangiopathy decreased from 10% to 0%, hepatic artery thrombosis 12% to 4%, primary non-function 4% to 0%, and sepsis or chronic rejection from 6% to 4%. So the last slide on pathogenesis, ischemia leads to reperfusion, which leads to the lipid peroxidase of the biomembrane. There's a membrane injury, which leads to the increased calcium in the cytoplasm and decreased ATP protection, which leads to the cell injury. So the organ procurement, usually in LDLT it is warm, but DDLT it is cold ischemia. But paradoxically, we have seen in last 15-20 years that even in the LDLTs, there is evidence of perfusion reperfusion injury. So this is the same repetition of the previous slides. So now I will take case wise. So it was a case. We received the biopsy on POD 11. Bilirubin was 5.3. AST and ALT are mildly increased. GGT was 50. Alkaline phosphatase 96. TLC 4.8. Creatinine 1.1. INR by 1.4. And the biopsy was done. So this is the 4 microphotographs of the biopsy, in which you can see the first photograph. There is a cholestasis. You can see the sinusoidal cholestasis as well as the hepatocytic cholestasis here. In second photograph, this is the higher power view. You can see the multiple cholestasis, but the inflammation is very less. And if you see the zone 3, you can see the necrosis or ischemia of the hepatocytes. There is a mild neutrophilic collection. You can see the central vein. The hepatocytes around the central vein are gone. They are replaced by the necrotic material, and it is there's a neutrophilic collection. So we made a diagnosis of perfusion reperfusion injury in this case, and after POD 32, with no added intervention, bilirubin decreased from 5.3 to 2.1. AST-ALT settled. GGT was normal initially, so there was no change. TLC was okay. So patient was responded without added intervention. So we have just given the time to the patient to recover and recover. So case 2 is we received the biopsy on POD 14. Bilirubin was 7.3. AST-ALT again marginally increased. GGT was 208. Alkaline phosphatase 112. And then TLC was very high, 27.8, creatinine 1.2. So these are the photographs. You can see there are a few area are preserved, which is usually zone 1 area which is preserved. And you can see the microvesicular steatosis, whole in the whole slide. So I will come to the second part. You can see there's a dilatation of the biliary duct, which is which is which is having this cholestasis, while then this area is somewhat preserved. Zone 3 and zone 2 both are replaced by microvesicular steatosis. So this is the first photograph, shows the zone 1, which is a portal tract and everything, which is slightly preserved, but again there's a dilatation, cholestasis, bile plaque there, and these are the photographs. So it was a case of ischemic cholangitis. So what was the course of the patient? After added antibiotic, the bilirubin came from 7.3 to 2.9, AST/ALT settled, GGT settled, then TLC reduced from 27.2 to 7.3, creatinine was 1.1. So ischemic cholangitis. The third case is we received the biopsy on POD 9, bilirubin was 3.7, AST, ALT are moderately increased, ALT was more increased, 228, GGT 67, alkaline phosphatase 103, TLC 7.8, creatinine 1.1. So in this case, we can see on the first photograph, there's an uplifting of endothelial membrane and there's a mixed inflammation, predominantly eosinophil. There are eosinophil and lymphocytes in this photograph. There's endothelitis. Then in zone 3, around the central vein, it's a radical changes of cholestasis, and there's a loss of hepatocytes around the zone 3. So on the basis of this, we have given a diagnosis of mild acute rejection with perfusion reperfusion. So usually in around 50% cases, perfusion reperfusion injury is combined with either with acute cellular rejection or with sepsis or ascending cholangitis like picture. Usually only in 50% cases you will see the pure perfusion reperfusion injury. So in this case it was acute cellular rejection with perfusion reperfusion injury. So the patient was given 3 doses of steroid, 100 mg. Not much steroid was given, because if you give the steroid, then it will again affect the ischemia. So the patient was settled from 3.7 to 2.7, AST/ALT settled, GGT, alkaline phosphatase, TLC, everything was settled in this case. So there are few other photographs of these cases. This is the biopsy of one patient that I received on POD 12. If you see, there's a bland biopsy. There's hardly any inflammation, but entire hepatic parenchyma is replaced by microvesicular steatosis. You can see in the diagram 2 and diagram 3, this is replaced by microvesicular steatosis. And after 2 weeks, again, we received the biopsy. Again, so you can see the microvesicular steatosis has disappeared. But if you see the second photograph, if I can enlarge it, but you can see the double nuclei. So it is basically a sign of recovery phase. So this is a recovery phase. You can see the central vein very beautifully. Central vein here, there's hardly any necrosis or loss of hepatocytes around the central vein. There's no inflammation. You can see in the second photograph there are 2 central veins. The both are normal. So patient recovered. Another case here is this is again, there's a cholestasis. You can see the area of cholestasis as well as microvesicular steatosis in this case. Probably we received after 2 weeks of transplant this biopsy. So enzymes were marginally increased there, and patient was sick. So they have done the biopsy after 1 week, like third week, uh, after 1 week of the previous biopsy. So we received the biopsy on the third week. So if you see, if you compare with the first biopsy, the microvesicular steatosis has reduced, the inflammation has reduced, uh, though there was not much inflammation in the first biopsy, but in the second biopsy, it turned out to be bland biopsy. So microvesicular status has improved. So the patient took some time to recover. I think he was in ICU for 35 days, but ultimately recovered. So this is my acknowledgement. Liver transplant team, we are doing a good amount of the work, good volume. Then constant of Department of Pathology, DNB student, my technical staff, Deepak Sharma, Nitesh Pandey, and technical staff of Department of System. I'm more than happy to answer your question. Thank you very much.
Thank you very much, Dr. Dheeraj. That was an excellent presentation, and you made difficult topics seem quite easy. So we will continue with the presentation by Dr. Bansal, and I request everybody to post their questions in the Q&A box, and also people who are watching this lecture on YouTube can also post their questions on the chat box there. And at the end of the second talk by Dr. Bansal, we will take questions for both Dr. Dheeraj Gautam as well as Dr. Nalini Bansal. So, Dr. Nalini Bansal's talk.
So, and they are interacting with. So, hello everyone. I am Dr. Nalini Bansal, and in this session we'll be discussing about the acute cellular rejection. So, we have discussed about some early graft dysfunctions like PRIs and other things, and we have also discussed the normal liver pathology. Now we'll be discussing one of the things that is very common in a liver transplant pathology, and that is acute cellular rejection. So the outlines of this talk are going to be why this T cell rejection occurs in liver. So when we talk of acute cellular rejection, we are actually talking about the T cell mediated rejection, and that is we are going to discuss why this rejection occurs in the liver. Then how does this rejection occurs in the liver, and why is liver considered as an immunoprivileged organ? So when we'll be discussing more about the antibody mediated rejection, we would learn that liver is considered to be little immunoprivileged and you do not require any induction for a liver transplant. So why is liver considered as an immunoprivileged? That also we'll be understanding. Then we'll be discussing about the clinical details of an ACR, how they present and what is the common derangement of the LFTs which is usually seen. Then finally, we'll come to the histological features of the ACR, and that is what shall be discussed in detail with you. And then we will be coming to the recent BAF classification, that is the rejection activity index, what is RAI and how is it being graded. So when we talk of T cell mediated rejection, or previously which was also known as acute cellular rejection, so the thing is going to start when the liver from the donor is put into the recipient's body. So we have cut a portion of the donor and that is being put into the recipient's body. Now, what will happen is, since this recipient is going to be a foreign material for the recipient, this organ of the donor, which is put into the body of the recipient, is actually a foreign thing which is transplanted into his body. So, the immune system of the recipient is going to get activated. And in this session, we'll be discussing about the T cell activation, which occurs secondary to the antigen expression, which is present in the transplanted organ. So as soon as this organ is transplanted and immediately after vascular anastomosis is performed, so there is a mixing of the blood, the passing of the blood from the recipient into the donor organ, and this will lead to activation of the recipient's immune cells, that is the T cells of the recipient. Now, once these T cells are activated, they are going to attack the donor liver. Not in all cases, in some of the cases they will get activated, and then they are going to attack the donor liver, resulting in derangement of the liver enzyme. So it is going to happen, and that is why we see T cell activation in the recipient's organ. So what we know is, on completion of the vascular anastomosis, once the vessels are like anastomosed to each other, the recipient blood is going to traverse through the blood vessel of the donor organ. So half of the portion of the liver that is being put into the recipient, now the blood of the recipient is going to pass through this newly transplanted organ of the donor. Now T and B cells are going to get activated by the antigen in the grafted organ, and then they are activated. So once they will pass through this organ, these cells are going to get activated, and then they are going to incite and elicit an immunological response to this body which is transplanted. So once the blood is going to pass through these sinusoids, and we have all have an understanding of the normal liver histology, that the blood flows to these sinusoids, and the blood that is coming into the liver is coming dominantly by the portal vein and also a portion of it by the hepatic artery. Now, since the blood that is coming from the portal vein is bringing all the blood from the intestine, so actually liver is exposed to n number of antigens prior to being transplanted. So now when the blood of the recipient is going to pass through this donor organ, there are some antigens on the donor cells which are going to interacting with the recipient's blood, and then they are going to elicit a T cell mediated response, which is also known as a cellular rejection. So once they will get activated, we will see the influx of these lymphocytes into the donor liver, and they may or may not elicit an inflammatory reaction to the liver. So now we have seen how the T cell mediated rejection occurs in the liver. Now moving on to the next question, why is liver considered as an immunoprivileged organ? So why do we not see so much of a rejection in the case of liver transplanted organ? So it has been shown that ACR, that is acute cell mediated rejection, they occur in around 20 to 25% of the transplanted liver. The clinically relevant ACRs, they are going to occur only in about 20 to 25% of the transplanted organs. So why we see lesser numbers of ACR in cases of liver transplant? It is because that, as I already mentioned, that the liver is containing a dual blood supply, which maintains a sustained low flow within the fenestrated sinusoidal system. So there is a large amount of blood which is continuously flowing through the sinusoids of the liver. So it is accommodating a persistent antigenic exposure without any sensitization. As we know that there are large number of antigens which are coming from the intestine on a daily basis to the liver sinusoids. So liver has become relatively immune to those antigens because it is exposed to n number of antigens. Then next is the liver parenchyma. We know is actually made up of only the liver cells. So largely 80% of the liver volume is composed of the hepatocytes. Now we know that since majority of the liver parenchyma is made up of liver cells, and all the liver cells, they have an exposure surface towards the sinusoids. So these liver parenchyma has got increased endothelial surface.
Yeah, there seems to be a
So that's why we call liver as an immunoprivileged organ, and that's why we do not see an induction therapy being given for liver transplant, which we usually see for the kidney recipients. So now we have understood why the liver is undergoing a T cell rejection. Now moving on to once a liver is transplanted, so how a clinician will get to know that there is some problem which is occurring in the liver. So the most common clinical presentation that is going to happen. So normally ACR is going to happen a month to 6 months, generally in the 6 months window period post-transplant, though there are cases where they can occur more than 6 months post-transplant. And about the late mediated rejection, we shall be discussing more in more detail in the later classes. So we'll be focusing ourselves mainly to the acute cellular rejection part. Clinically, these patients So now at this point, when they're having this fever, malaise, upper quadrant pain, so at this point, which is relatively early on post-transplant, say 1 to 6 months duration, so there are n number of things which will come into the differential diagnosis. So they could be your viral mediated pathologies, especially CMV. Then they could be your in the early phases, it could be your primary liver dysfunctions in the form of PRIs and SFS that we have discussed already. Then they could also be like viral pathologies, and there could be some sepsis condition. Infections can also lead to this kind of a picture. So there could be n number of things which will come on into this period, and they all are going to be differentiated from other pathologies, including the ACR. So what we need to do, so once the patient is having a derangement of LFTs, and this derangement of LFTs could be in the form of rise in bilirubin, it could be in the form of transaminitis where OTPT are going to be deranged, or it could also be in the form of increase in serum alkaline phosphatase. GGT is considered less because GGT elevation is normally seen early in the post-transplant period. Diagnosis of the ACR. So what a clinician is going to do? So what he is going to do a liver biopsy, because liver biopsy, if being done, is considered diagnostic for this acute cellular rejection. So they are going to differentiate this ACR from all the other pathologies, and for that, a liver biopsy is a must. Then we want to know whether it is a cell-mediated rejection or it is some other pathology that we have already discussed. So now this thing about the liver transplant rejection has originated from the BAM classification, which was originally given for the renal recipients, renal transplant pathologies, and it is nearly 25 to 30 years old, where in 1991, the first classification of BAM has come for the renal recipients. Then subsequently, it was extrapolated for other organs, and now we know there are every 5 years, there is an
There seems to be a little glitch in the thing. There is we've requested the technical team to fix it. Yeah, it is getting the video is getting hanged. It's pausing basically. So may I request Dr. Nalini, if you have your slides ready, then maybe we can.
Moving on to the first triad, the first component of the triad, and that is your portal inflammation. So we all know that portal in the normal liver, the portal inflammatory infiltrate is usually occasional 1 or 2 macrophages, and sometimes there could be some sprinkling of the lymphocytes there. But normally more than 5 lymphocytes, we generally don't expect to be seen in a portal tract. So when we are seeing an increased number of inflammatory infiltrate, and this is little subjective because when we have seen many liver, then you get to know that yes, there is a little elevation in the portal inflammation, and that we are going to find. Now this inflammation, if it is increased, we are going to look at the component of the inflammatory infiltrate. That is, what kind of cells are present within the portal inflammation. So whether these are lymphocytes, and as we said that these are basically the T cell mediated lymphocytes. So these are CD4 and CD8 positive T cells. So whether the component is made up of lymphocytes, eosinophils, neutrophils, macrophages, and there could also be some lymphoblasts which are seen within the infiltrate. So when we talk of rejection infiltrate, we are actually talking of a mixed component of infiltrate, which is in the form of dominantly lymphocytes, and there is also a fair proportion of eosinophils, neutrophils, macrophages, and some blast cells. Now, these blast cells, they are different from the lymphocyte because they are relatively larger in size as opposed to the normal lymphocytes which are seen in the infiltrate. So normally the rejection infiltrate is usually mixed in nature with a component of all of these. Now, when we talk of these infiltrates, so as I said, there could be some eosinophils also within the infiltrate. And when we see eosinophils elsewhere in the liver, the first differential that comes to our mind is this a drug-induced liver injury? So we have to be very careful when we look at this infiltrate, what is the component, where it is present, to differentiate them from the drug-induced liver injury from actually the rejection infiltrate. And if we see neutrophils, we need to differentiate them from the biliary pathologies. And then blasts are relatively specific for portal inflammation of rejection infiltrate. They are rarely seen in other pathologies. So now let's go back and look at some of the normal portal tract and how are you going to differentiate from a rejection infiltrate. So this is a normal portal tract. And as I said, you could see occasional lymphocytes, 1 or 2. Here and there per hyperfield, you generally see not more than 4 to 5 lymphocytes. So that is in the normal portal tract. There could be some sprinkling of the inflammatory cells, but they are generally lymphocytes. You fail to see a component of like mixed inflammation as we see for the T cell mediated rejection. So we would find a hepatic artery. There could be 1 or 2 bile ducts, and this is the portal vein. So in a normal portal tract, there is no ductal inflammation, there is no endothelial inflammation, though there could be some lymphocytes. So now you need to differentiate this normal lymphocytic sprinkling again from a mild rejection infiltrate, which is at a very borderline category. So this has to be
We'll have presentation slides from Dr. Nalini. She will do it live. The video is showing some technical problems. Huh?
yeah, I think
Please continue, ma'am.
Yeah, okay. So this is what we were discussing. So this is a normal portal tract, and then we have got the rejection infiltrate. So as you can make out from this image only that there are presence of like mixed inflammatory cells, and we could see a fair proportion of EOs as well as the lymphocytes. So when you see this kind of an infiltrate, then you know that you are dealing with the rejection infiltrate, and this is what you need to differentiate from a normal portal tract. So that was about the T cell mediated rejection. Now, next is there could be the rejection infiltrate. We need to tell about the grades of this rejection infiltrate, whether it is mild, moderate, or severe. So we are going to look at the amount of inflammatory cell. That is the first thing that we are going to tell. And then we are going to tell whether it is confined to the portal area or it is coming out of the portal area. So here we are finding that this again is a tract with relatively mild to moderate infiltrate. And in this tract, we could find that there is presence of this mild inflammatory infiltrate. Now, one thing is if you are having only the mild infiltrate, you should be very careful to differentiate them from drug-induced liver injury. Generally, the drug-induced liver injuries could have a variable pattern. They could be cholestatic, hepatic, or they could be other morphologies which you can also see. And the presence of occasional eosinophils should be accompanied by the presence of ductal or endothelial inflammation when you are relatively confident that this is occurring in the rejection background. So that should be taken care of. Now, coming back to this liver slice, now as you all can make out here, as you all can make out, so this is a moderate degree of rejection infiltrate, and there are some occasional like sparse lobulatory inflammation here and there, but dominantly the pathology lies within the portal tract. Now, this in the second image that is being shown here, this is showing you a severe degree of inflammation, and here the inflammation is not just confined to the portal tract. Here, the inflammatory cells are also spilling into the adjacent parenchyma. So the first and the foremost thing in the triad that we have to look for in ACR is the presence of portal inflammation and whether this inflammation is of mild, moderate, or severe in nature. So that is what we are going to assess in the biopsy tissue. Now, moving on to the second portion of the triad, and that is your ductal damage. So second thing that you are going to look for is you are going to look at the bile ducts in the portal tract. And then within these bile ducts, you are going to see the evidence of ductal injury. Now, this ductal injury could be identified by the presence of these intraepithelial lymphocytes. So, let's see here. Okay. So, these could be seen by the presence of these intraepithelial lymphocytes, like these. So, this is the bile duct here, and you could find the presence of these lymphocytes which are coming into the bile duct. So, presence of intraepithelial lymphocytes is very specific for a ductal related damage, and that indicate that there is some ductulitis going on there. Then as a result of this damage which is occurring to these ducts, you are going to find the eosinophilic cell change of the epithelial cells. So normally the ductal epithelial cells, they've got an amphiphilic nature of the cytoplasm. So the cytoplasm is relatively amphiphilic, and when these cells are damaged because of infiltrate of the lymphocytes, the cytoplasmic color changes. So there is a change in the color of the cytoplasm, and instead of being an amphiphilic in nature, they would now assume a eosinophilic appearance. That again is going to tell you that yes, there is some damage that is occurring to the bile duct. Then moving on to the third thing that we are going to see in the ductal system is your cytoplasmic vacuolization. And that is also known as vacuolar injury, similar to what we see for the lichenoid type of inflammation. So there is going to be these cytoplasmic vacuoles within the ductal epithelial cells, and there could also be some clearing of the cytoplasm. And finally, as a result of this lymphocytic infiltrate, there could be loss of nuclei. So when you see a spectrum of these changes, or when you see some of these changes, then that is the time when you are going to call it as a ductal damage, and you are going to call it as a ductulitis. Now, as a result of these changes, sometimes the duct will look very atypical, and they would look as if there is some pleomorphism, there is some atypia which is going on within the duct. So let's see some of these. And let's see the third component of these. So the third component of the damage is your endothelial damage, and that is the third triad of this rejection infiltrate, and that is your endothelial damage. Now, this endothelial damage can be identified by the presence of these subendothelial lymphocytes. So normally in the vessel wall, you do not find a significant pooling of the lymphocytes in the subendothelial location. And then the next is you are also going to see presence of endothelial cell injury, in which the endothelial cells are going to swell up, they are going to enlarge in size. The third thing you are going to see is the presence of endothelial cell upliftment and detachment from the basement membrane. So now instead of their resting position, they are going to come up and they would going to come into the lumen. And finally, in the later stages, you are going to see the loss of endothelial nuclei. So all these changes can come as a part of endothelial damage. And the area that where we are going to look for it is, we are going to look for it in the portal vein, central vein, and the inlet capillaries. So that is the area where you are going to look for the endothelial damage. Now, another important thing is in the endothelial damage, we are not counting hepatic artery. So that is a very important thing to be remembered, that when you are seeing the portal tract, you are not counting the inflammation or the endothelial damage of the hepatic artery. So that is immaterial to us. What we are interested in is actually the presence of the portal vein and the capillaries. That is similar to what we see in the renal area. So, okay. Let's clear all this. Okay. So now this portal area, this is one portal area that we are seeing here. And this is, as you all can make out, this is the bile duct, which is evident. So this is your bile duct here. And in this bile duct, we have got the vesicular nuclei, which are the normal ductal epithelial cells. They are vesicular, and when you are in doubt, you can compare them with the adjacent hepatocyte nucleus. So that is how you are going to assess the nature of the bile duct epithelium. So because in cases where they are completely damaged, it becomes very difficult to differentiate the ductal epithelium from the damaged cells or the inflammatory influx to the portal area. So this is the bile duct that we are finding here. And in the bile duct, we are getting the bile ductal epithelial cells. And in addition, we are getting these small hyperchromatic nuclei, which are actually the influx of lymphocyte into the ductal epithelium. Now we know that this ductulitis is occurring as a component of this portal infiltrate. So there is something more to this ductulitis, and that is the presence of this portal inflammation. Now, when we are assessing the liver for ACR, one thing is very important, that we are not looking at a single finding. We have to see everything in a spectrum of changes, and then we are going to come down to a conclusion that whether this is actually an ACR or this is something else that we are dealing with. The reason why this is so important is because in ACR, the biopsies are done basically for the diagnostic evaluation of ACR. So you have to rule out all other differentials before you really say that this is an ACR. So that is your ductal epithelium, and that is an evidence of ductulitis over there. So now moving on to the next portal area. So look at this portal tract. Here again, as you all can make out, this is the ductal epithelium. But here the nucleus look little bizarre. They are like looking more degenerative. There is anisonucleosis of the nuclear shapes and sizes. And then at some places we are seeing the loss of nucleus. So the nucleus are not uniformly distributed throughout the ductal epithelium. There are some areas where there is a loss of nuclei, some areas where they are enlarged, and some areas they are showing this apoptotic change. So there is a morphological changes which are going on into the duct. And now we know that this duct is actually showing you some degenerative changes in addition to the portal infiltrate that we are finding here. So that was another portal tract. Now in this biopsy, if we look carefully, now in this portal tract again, we are finding that there is a lymphocytic, there is a dominance of inflammatory infiltrate in the portal tract. And if you look at the bile duct here, in this duct, there is actually loss of all the nuclei. So what we are finding is, so this is the duct here. And in this duct, what we are seeing is there is loss of the entire nuclei. And some of the nuclei have become flattened. In most of the areas, the nuclei are lost. And in more other places, it is looking very much atrophic or dystrophic, we can say. So that indicates that there is some ductal injury that is going on. And again, in this duct, what we are finding is that this is the cytoplasm of the duct. And here there is a lot of cytoplasmic vacuolization. That again is an indication that this duct is undergoing some degenerative changes. Now here, in addition to this cytoplasmic vacuolization, we could also see that there is some disruption of the duct lumen. So as the disease is going to progress, as the T cells are going to infiltrate the liver parenchyma and into the portal area, they are going to cause a damage to the ductal epithelium. And since there is a damage to the ductal epithelium, so what we see is what will result in the biochemical testing. So that will lead to some increase in the alkaline phosphatase of the patient, and that is usually a spectrum that we see in cases of acute cellular rejection. So this is actually the duct, and if the duct is damaged, it is very difficult to identify the duct from the rest of the inflammatory infiltrate. So that was about the ductulitis. Now moving on to the third component of the triad, and that is your endothelitis. And now look at this vessel wall. So as I said, the first and the foremost rule is you are going to look only and only at the venous profile, and you are not going to look at the arterial profile. So we are not going to assess the hepatic arteries here. We are only going to assess the portal venous profiles. So now this is a portal vein profile, and we all are aware that there are endothelial cells which rest on the portal veins membrane. So these are the normal endothelial cells here, which are like distant apart. Now here, if we come down in this area, we could see that there are many lymphocytes, these hyperchromatic nuclei, which have now come and arranged in a position in the subendothelial location. So once we see that the lymphocytes are coming down and moving towards the endothelial cells, that means these T cells are getting, they have an affinity towards the endothelial cells, and they are moving closer and closer towards the endothelial cells. So now when the T cell would move and have an affinity towards the endothelial cell, they are going to come and align in the subendothelial location as is being seen here. So this is what is called as a string of pearl appearance, where most of these are going to come and align in the form of a garland around the endothelial wall. So if you see this change, that again is an indication that what you are dealing with is actually the changes of an ACR. So as I said, you need to differentiate ACR very beautifully, and you need to differentiate them confidently from the rest of the pathologies that we have already discussed in the previous sessions. So that was about the morphological spectrum of the ACR. Now moving on to the next thing in MARM that they have discussed, and they have come down with the criteria how you are going to assess when to start therapy in cases of ACR, and when we are going to say that this is really severe and it may or may not respond to steroid. So based on the assessment of different liver biopsies, and I've been really lucky to be a part of the norms which are a part of this BARM group. So now there they have assessed number of biopsies and they have come down to these scoring system, which are actually given in a total RAI score of 9. So out of these 9, you give a total rejection activity index as it is being called, and that is the RAI rejection activity index. Now, as I mentioned previously, there is a triad of things that you are going to look into it. One is your portal inflammation, bile duct inflammation, and finally the venous endothelial inflammation. So these are the three things that you are going to assess. And for each of these three parameters, we have three grading system, 1, 2, and 3. Now, when we move from 1 to 3, the degree of these activity are going to increase. That means as we move from inflammation towards the portal tract damage, now they are going to leave the Lakshman Rekha and they are going to spill out. So in the portal inflammation in grade 3, you have the portal inflammatory cells which are going to spill into the adjacent parenchyma. They will cross the limiting plate and now there is no Lakshman Rekha that is dividing the portal from the hepatic parenchyma. The next thing in the bile duct inflammation when we talk of, in the bile duct inflammation, if there are degenerative changes in few, in many, and finally, if there is luminal disruption, then that is being the severest grade of the bile duct inflammation. Now, the third triad is your venous endothelial inflammation. And in this again, when we talk of endothelial inflammation, there is involvement, in addition to the portal tract, there is involvement of the central vein also, which can be seen in the grade 1 and grade 2 as well. But in the grade 3, in addition to that central vein involvement, you are going to see hepatocellular damage. So here, the hepatocellular damage would start occurring, and that too in the zonal fashion. So you are going to see a loss of hepatic parenchyma surrounding the portal vein. So that is when you find these changes, then you are going to call it as a gravest degree of endothelial damage. And when we find these, we are going to discuss it more. We sometimes straight away call it as a LAR. Now, this is the semi-quantitative scoring system as proposed by Banff, and I know why Banff is so popular amongst them, because that is one of the most beautiful mountain national park that is there in Canada. So that's why they conduct every 5-year a meeting is being conducted over there, and they come up with newer and newer modifications in the already existing system. So what is this semi-quantitative scoring? So once you have calculated the score from 0 to 9, you are going to call it as indeterminate when it is 1 or 2. That means you are not sure whether it is actually rejection or not. Then this could be mild when it is 3 to 4, moderate when it is 5 to 6, and it is severe when it is more than 6. So that is how you are going to score your rejection activity index, and you are going to tell that the rejection is mild, moderate, or severe. Now, for the milder grades of rejection, generally no therapy is given, or sometimes at some centers they do give a steroid intake, lower dose of steroids are started. And in the moderate degree of rejection, they would definitely start the therapy. So that is how your biopsy findings are very important when it comes to your treatment perspectives of the patient. This is because if you are treating it very early, you can still avoid this going into a case of severe AR, or you could still avoid going into a cases of chronic rejection, which occurs in around 10 to 12% of these cases. And once it progresses towards chronic rejection, it is really difficult to treat the patient. So that is why the biopsy proven diagnosis of ACR is very important, and that is how you're going to do it. So that is the semi-quantitative scoring system. And in the recent MARM classification 22, though it has not been published yet, they have proposed one more index that should be given along with the triad that I have already mentioned. And that is especially true for the later cases of ACR, that is your interface activity. So interface hepatitic activity index should also be given in addition to these, but that is not yet validated as such. So that was about the morphological features of ACR, how you're going to diagnose an ACR, and how you're going to give the grading system of the ACR. Now moving on to the course of ACR, how these patients are treated. So early cases may or may not get steroid, but even if they get steroid, they are generally responsive. So they respond very well to the steroid therapy. In the severe cases, they could be steroid resistant, And that's why it is so important to diagnose them early on. And if they're not responsive, you may need to give an ATG in those cases. And then the cases which are refractory, they can progress to CR, that is chronic rejection. And in these are the cases which we are trying to avoid with the help of these diagnosis of an ACR. So this was one of our papers that was published in IGOT, that is the retrospective analysis of post-transplant biopsies. So if you all can go through it, we have also published a review in this for the liver transplant pathologies. So with this, I conclude the session. And if there are any questions, we can take them up now.
Wonderful. Thank you very much. That was an excellent session on acute cellular rejection, ma'am. So, time for questions. So far there is one question in the chat box by Dr. Tejal Shah. So her question is whether eosinophils in the portal tract will also have a differential diagnosis of acute on chronic cholangitis in compared to acute rejection. So Dr. Bansal, please.
Yeah, so now in this, if you have eosinophils, yes, cholangitis would come into picture. But then this cholangitis is going to be very different from what you see. So as I said, never go for a single finding, never go for a single cell in the liver biopsy. You have to look for other features of cholangitis. You have to look at the clinical picture of the patient. And then you have to look for the, not just these eosinophils, you have to look for the presence of polymorphs within the ductal lumen. When we talk of rejection, we are basically interested in the T lymphocytes. So I'm sorry, I missed that part. So acute cellular rejection these days, they are now called as T cell mediated rejection, and that is the current terminology which is used by BAM. And why it is called T cell? Because we are interested only in the T lymphocytes. The secondary influx of the inflammatory cell is because of the cytokines which are released by these T cells. But the ductal damage that we see is largely by the lymphocytes. So there is a different spectrum of cholangitis when you find there. But yes, in eosinophils can be seen in cases of cholangitis. So
Wonderful.
I hope that answers your question.
Second is, I have a question for Dr. Dheeraj. So, sometimes you see just intrahepatic cholestasis when you do a biopsy early after transplant. And even though the liver quality may be good, and you have ruled out vascular problems, you have ruled out a biliary obstruction, everything, but you'll just see intrahepatic cholestasis that doesn't settle down quickly. So what is that? What does that indicate, and what is the reversibility of that situation?
Dr. Ravi, liver transplant pathology is not a isolated science. You have to speak to the clinician, then only you can make a diagnosis, a complete diagnosis. But yes, the clinical picture of cholangitis versus perfusion reperfusion injury versus acute rejection is totally different. In acute rejection, the enzymes would be very high. In cholangitis, the TLC would be high, and the CRP and all the inflammatory marker would be high. In perfusion reperfusion injury, you will see only mild increase in the enzymes. What you have seen in all my cases, the SGOT and SGPT were around 70 to 80 range. But histologically, if you see, if I'm not finding microvascular steatosis, and if the zonal segment, what I experienced in 50-20 years, the zonal integration is very, very important in perfusion reperfusion injury. If it is not zone 3, then probably it is not perfusion reperfusion injury. So,
yeah. So now
the chances of reversibility are very high.
Why?
In this
Yeah, that is the point we wanted to drive home for all the audience.
Exactly.
Now, there is a question on antibody-mediated rejection, but there is a separate session for that in the next time. But anyway, very briefly, Dr. Sandhya is asking what are the changes to look for in antibody-mediated rejection and when to ask for C4D staining. So, ma'am, if you can just briefly answer this, because there's a full talk on this the next time actually.
So she's asking when to ask for a C4D staining.
And what other changes to see in for antibody-mediated rejection AMR?
So, like as Dr. Ravi sir has already said that there is a full session on that. So I just cover it very briefly. When you talk of antibody-mediated rejection, we have seen cases of AMR occurring in ABO-compatible as well as incompatible patient. That is first thing. So when you see liver transplant biopsies, it is not always true that the patient has to be ABOI. The patient could be ABOC, and again you can see a antibody-mediated rejection. So routinely, what is required is you should do a C4D staining if there is a little histological evidence that it is going into the lines of a acute antibody-mediated rejection. Histologically, the features lie mainly in the portal tract, and then in the hepatic parenchyma, you are going to see areas of hemorrhagic necrosis. Now, this word, when I say hemorrhagic necrosis, this is very important because this hemorrhagic type of necrosis is very different from all other types of necrosis that we see. Now, initially to start with, this hemorrhagic necrosis can be just a small speck of hemorrhagic necrosis, and that speck can be seen in the periportal region. That speck can be seen within the lobular parenchyma. The classical thing that has been described in AMR is your perivenular hemorrhagic necrosis, where there is a loss of hepatocytes and that area is replaced by your complete hemorrhagic tissue. In addition, the infiltrate that is occurring in cases of AMR, so we know antibody-mediated rejection is facilitated with the release of these antibodies and the complements. Now, these are basically causing an influx of polymorphs. So the first cell that you are going to see in cases of AMR that should raise a suspicion that this could be AMR is your polymorph. So once your balance is tilting from the lymphocytes towards your polymorphs, and then in addition, you're finding the areas of these hemorrhagic necrosis, then you are going to do for sure a C4D in that cases. For C4D control, you can take a renal tissue. It is not absolutely necessary that you take a liver parenchymal tissue to look for C4D staining. And there is, for C4D again, there is a huge spectrum of staining patterns. So I think that shall be covered in the later sessions also. Yeah. So I'll not speak much on that. But the classical is you are going to look for that stromal, staining pattern in the portal venules and in the capillaries. So maybe in some other sessions, we can share those pictures also. Yeah. So the involvement of this C4D staining should be within the inlet capillaries, sinusoidal venules, and also within the portal venules. And this has to be, there are different grades for this. That is whether it is only in one of the portal tract, like less than 10%, 10 to 50 or more than 50%. Then accordingly, you decide that C4D grade is like mild, moderate or severe. So when you are suspicious on histology, then for sure you are going to do a C4D. And the suspicious features are your areas of hemorrhagic necrosis, your more influx of polymorphs. And then in addition to that, there are cases where you would find that within the inlet venules and capillaries, you are finding the presence of polymorphs similar to what we see in the renal tissue. So that is in the recent BAMF, they have said that similar to what is described in the renal, that is peritubular capillaritis, similar changes you are going to see in the inlet venules. So I hope that answers the question.
Nice. So Dr. Dheeraj, you wanted to add something?
Yeah, I just want to emphasize on one point here. Just because I have seen more than 3,000 or 4,000 biopsies, but I missed two antibody-mediated reaction. So my point to emphasize here, if you find cholangitis picture with hemorrhage, always suspect antibody-mediated reaction. Just because is clinical picture of antibody-mediated reaction is very perplexing. Very perplexing. So if you find cholangitis with hemorrhage, always suspect in the background it could be antibody-mediated rejection.
So the next question is for both of you. We'll start with Dr. Dheeraj first, and ma'am will request your answer also. So this is a very common situation where we have abnormal LFT, and as clinicians, we'll give a couple of doses of steroids. And then you see a biopsy which is not classical of either rejection, nor it is classical of a preservation injury. You just see some necrosis, you just see some cholestasis. So in this situation, how do you come to a diagnosis? So Dr. Dheeraj first.
Okay. So first you have to see the clinical history as well as the trend of the enzymes. What was the enzymes level before giving the steroid, and what is the enzyme level after after giving the steroid. Usually the acute rejection respond very well unless otherwise it is refractory. It is very well respond with the steroids. Second thing, there are three components of acute rejection, that is portal inflammation, ductitis and endothelitis. So after giving the dose of steroid, they reduce first one is portal inflammation, second is ductitis, and third, the last one has to go is the endothelitis. So you have to see these changes according to the order and speak to the clinician. Then only you can come to the conclusion.
Wonderful. Ma'am, your comments.
Yeah, now, as you're saying, you have given the steroids, and then after steroids, the biopsy is taken.
Yes.
Yes? Yes. So after steroids, if the biopsy is taken, as Dr. Dheeraj has already mentioned, the inflammation is going to subside. That is for sure, because steroids are suppressive to the inflammatory cells. But as he said, if there is evidence of ductitis and endothelitis, then still we are going to call it as a rejection only. So if there are areas of necrosis, then there could be something added pathology other than your ACR that is being seen. So when we talk of ACR, we are basically talking of two main pathologies, whether it is a portal dominant thing or it is a lobular dominant thing. When we talk of rejection, rejection is basically portal dominant pathology. So when you are given a steroid, there is a decrease in the portal inflammation. But this, if there is a dominance of lobular pathology, that means there is something more to that ACR, even if your ductitis is present. So that could be your CMV reactivation, that could be your drug-induced liver injury. Like it could be sometimes we have seen tacrolimus-induced injury to the liver parenchyma, and then you should go back and look at the TAC levels, whether the TAC levels are really raised or they are at optimum level. And then we may need to change the immunosuppression. So if there is a dominance of liver-associated changes, then there is something add more than that what we see usually expect in a case of ACR, and that has to be looked for in the biopsy tissue. So you have to look at the continuum of changes, and then we'll come down to a diagnosis.
Yeah, so basically that's a good way to summarize this session, is that if you see predominantly inflammatory changes, then think more about rejection. If you see cholestasis, necrosis and other changes, then think of other pathologies also. Because unfortunately, as clinicians, we are guilty of this, that if you see a little rise in the enzymes, you are reluctant to do the biopsy and you tend to treat it first. So have a low threshold for doing the biopsy before treating. And of course, if it is not responding well, then follow-up biopsy will generally answer the question. Wonderful. Thank you very much, ma'am. Thank you very much, sir.
Thank
This
you.
was an excellent
Thank you.
session. And I'm sure
Thank
all
you.
participants benefited from this interactive session and with such a good discussion. So we'll close this session now. And I again wish to thank both faculties, both speakers on behalf of ISOT for your participation and excellent talks.
Thank you very much.
Thank you all participants
Thank
for
you.
being part of this also.
Thank you.
very
Thank
much.
you. Okay.